I would now like to invite Dr. Sunil Karanth next to talk to us about lung ultrasound in COVID-19. Dr. Sunil Karanth is Chairman and Consultant of Critical Care Services at Manipal Health Enterprises and the Chairman of Hospital Infection Control Committee. He's fellowship and training in critical care medicine in Australia, Europe, and India. He has 3 formal qualifications in critical care medicine in India. He's a pioneer in specialty of critical care and neurocritical care, and also the pioneer in the utility of ultrasonography in ICU. He has numerous publications in the national and international journals, chapters in many national and international books, and he's a member of the Indian Society of Critical Care Medicine. Over to you, Dr. Karanth.
Good evening, everybody. Thank you, Arpita. So after a gross overview on the use of ultrasound, I will just deep dive into lung ultrasound, specifically in this pandemic times, in the COVID-19 times. Why ultrasonography of the lung? As you know, the last 1 decade, there has been an increasing popularity of the use of ultrasound for a variety of procedures and screening that we use in critical care. And it is now termed as point-of-care ultrasound, focused ultrasonography. A lot of names have been given to this fabulous tool, and from its usage as a screening tool for echocardiography, hemodynamics. Today we talk about using ultrasonography as a significant screening tool and a part of the clinical examination armamentarium in the ICU as well. Now, why did we choose ultrasound, or why ultrasound has taken its birth into the as a point of care tool? There are a lot of disadvantages of having an imaging technology like X-ray. As you know, irradiation, there's limitation of information. It is a 2D kind of image that we get. And to add to this, the ultrasound has its own set of advantages, being the clinical safety profile, at least from a theoretical aspect of having no radiation, and most importantly, significant sensitivity and the portability. With a short learning curve, there seems to be a good degree of what we call as reliability with the use of ultrasound as a usual, as a routine screening tool. Now, some key principles of ultrasonography or lung ultrasonography that we need to understand is always try to use a simple equipment which is not very complex, not very cumbersome to move around. So portability of the equipment is extremely important when we choose the right machine. As we have seen with the Vscan tool, something similar to that, very portable is very important to ensure that the usage or the utility of this equipment in a very constrained environment like the ICU is topmost. The gas and fluid interface which is present within the lung, which is the sine qua non of a lot of pathologies within the lung parenchyma, is what we use to create artifacts, and it is these artifacts that are actually studied when we talk about using ultrasonography as a screening tool or as a tool for use in lung pathologies. Large voluminous organ, the lung being a large voluminous organ, you have to make sure that you have standardized the areas of examination. Now, it's very important to understand that these examination areas that we know in clinical medicine is very much applied for examination of the lung, and therefore there are now numerous protocols that we today have. You can have your own protocol as it's already been described, but it's important that you have a simple protocol which you can use repeatedly on every patient, and that will also give you a standardized way to assess the lung. All signs are linked to the pleural line. So it's very important to understand that there is a pleural line, which I will show as we move further, which will be the starting point of examination of the lung in using lung ultrasound. Static signs are generally what you see is artifactual, and the signs that we talk about, even if it is dynamic, is always going to be in relation to the pleural line. And for all practical purposes, life-threatening disorders which are in relation to the pleural line are important to understand because they explain the potential of lung ultrasound. Now, what are the probes that we use? As you know, there are a variety of probes which we can use. It's important to have a probe which has a fairly flat footprint and a high frequency. So the preferred probe is what is called as a microconvex probe, which was the first probe that was described by Dr. Daniel Lichtenstein when he first used the ultrasonography as a screening tool or as a device for lung ultrasound. This is a tool. This is a probe which has a configuration of or a frequency of between 5 to 8 megahertz. Now, this actually is the optimal tool to use or optimal frequency to have, because it is a mid-range frequency which is not too very high nor is it too very low, and this one particular probe can be used for all modalities of examination in the ICU when we use the ultrasound. But the vascular probe is probably the best if you talk about lung ultrasound because of its high frequency and its flat footprint. But we should understand that it has its own sort of limitations because of the very high frequency. You find that the penetration of this is actually not very good. Now, there are suggested examination methodologies, and most importantly, what we need to understand is that you need to have your own set of examination areas that you can come up with. One of the common methods is the 6-point method, which has 3 points on the right and 3 on the left. You could divide the chest into three major areas called the upper blue point, lower blue point, and the flaps point. The full form of flaps is posterolateral alveopleural syndrome, which actually which actually shows the posterior inferior point recess of the lung, recess of the pleural cavity. Okay. Now, how do we measure these things? It's important to keep two arms, one on the front of the chest, one above and below, and that will actually mark the upper blue point. The center of the upper hand will be the upper blue point, and the center of the lower hand will become the lower blue point. Now, when you actually draw an imaginary line from the lower border of the lower hand down to the posterior axillary line, as you can see on the right hand photograph or the figure, this is where the flaps point is. Now, this is a imaginary point which you need to examine, which you mark out by using what is called a surface marking. But once the ultrasound probe is placed, we may have to alter the probe accordingly to ensure that you get to the inferior posterior most part of the recess of the pleural cavity. Now, in COVID-19, people have further described two other sections, wherein the upper and lower blue points are divided into two halves by actually drawing a line, which is the anterior axillary line. So between the anterior and the posterior axillary line, you can create two more lateral sort of quadrants, and that will further give you a little more specific, a little more precise marking for the lung. Now, this is this would become a 4 quadrants on one side, or what we would call as an 8-quadrant methodology. Now, certain specific terms that you need to understand. A-line, this is the architecture of how a normal lung will look on an ultrasonography film or an ultrasonography screen. You have the pleural line, which is the uppermost parallel line which runs parallel to the screen, and there are multiple lines which run equidistant from each other, or multiple parallel lines. These are nothing but reverberating artifacts that we see, and when you find A lines parallel to each other, it means that the lung parenchyma is normal. These are not true lines. As I said, these are reverberating artifacts where the reflection of the pleura is seen at equidistant from right to the depth of the entire screen. B lines are pathological lines, which are perpendicular lines running from the pleural line. Again, if you mark my words, I'm saying that the index of or the index line that you always need to remember is the pleural line. So anything that we talk about with lung ultrasound is the pleural line, because that is one of the most consistent structure and the consistent line that you are going to get on the ultrasonography screen. So from the A line or from the pleural line, multiple perpendicular lines which go to varying depths down to the entire length of the ultrasonography screen is what you call as B lines. Now, a word of caution here is to make sure that you differentiate B lines from what are called as comet artifacts. Many times in a normal lung, you do find that there are A lines, as you can see, and you might find short perpendicular lines which run from the pleural line to a short distance, not even touching the next parallel line. These are called comet artifacts. So it's important to make sure that the length of the B line is right across the length of the screen, and with the depth of the ultrasound being placed between 6 to 8 centimeters. So if you have a very superficial or a very what we would call as a magnified view of the pleural cavity or the pleural line, you might actually be having a depth of only about 2 centimeters, and it is there's a very high possibility of you overreading a comet artifact as a B line. So it's very important to understand the difference or to identify or to differentiate a B line from a comet artifact. Now this is how a normal lung would look. What is called as a comet, what is called as a bat sign. Essentially what happens is you've got two rib artifacts which are there, and because of the fact that because of the presence of the rib, there is no shadow of the lung that you would see. So this is called a bat sign, where you would see the rib shadow on either side, and in between you would see the A line, which would produce the classical bat sign. Now, if you put an M mode on this, you would see what is called as the seashore sign. This is the moving lung, and that is the soft tissue, and this is what you see as a normal lung, and this is the pleural line. So that's what you would see on a normal lung architecture. If you play a video of the same, this is how the video would look. You find that there are two ribs here, and there's a rib artifact coming below that where you cannot see any, or the rib shadows are seen, and you see a pleural line here, and you see the pleura sliding with every breath or with every respiratory cycle. So this is called as the bat sign, which is the normal, which is what we see as a normal architecture of a normal lung. Now let us look at some of the pathologies that we would normally see. Let us start with the PLAPS point, because most of the pathology, or if you look at the patients who are bedbound in the ICU on a ventilator, most of the pathology starts in the posterior inferior most part of the lung for a variety of physiological reasons which we are all aware of. This is how early pleural effusion would look at the PLAPS point. That's called the quad sign, where you actually see that there is a quadrangular structure that comes, which is boundaried by, on one side, the pleural, the visceral pleura of the lung, the other one, sorry, the visceral pleura of the lung, the other one is the parietal pleura of the lung, and the rib shadows on either side. That is what is called the quadrangular sign. And when you put a M mode on this, you find that the lung keeps coming in and out, moves in and out, producing what is called as a sinusoidal sign. Now, this sinusoidal sign is the first or the earliest, one of the earliest signs in the PLAPS point to indicate a very early pleural effusion. So if you look at the right side of the lung or the PLAPS point, you find that the lung would, that the PLAPS point structures would look like this. You've got the lung on the posterior inferior part of the diaphragmatic recess, you've got the diaphragm, you've got the liver and the kidney. Now this is a structure that is very important to understand and recognize, because this will be the starting point of any examination on when you start with the PLAPS point on the right side of the at PLAPS point. Now, if you look at a much larger pleural effusion, if you look at a much larger pleural effusion or a large pleural effusion, this is what an effusion would look like. You find that the large fluid collection in the lung, in the pleural cavity, and you find that the lung is actually floating in this mass of fluid. Underneath that is the liver. So this is how extrinsic collapsed lung would actually look when it is actually floating in a fluid. And this is, some people mention this as a worm sign. A whole lot of signs are present for this. Essentially, you find that the lung is floating in a large mass of pleural fluid. Now, next important pathology we know about is the lung consolidation. There are 2 or 3 important signs to recognize when we talk about lung consolidation. The most classical sign phenomenon consolidation is what is called as the tissue pattern or a tissue sign, which is nothing but a translobar consolidation. Now, all of us, if you remember how we looked at our pathology, there is a stage called a stage of hepatization in when pneumonia develops, classically seen in lobar bacterial pneumonia. So if you have a consolidation which is very thick, which looks like a hepatization, which is in the phase of hepatization, you find that this consolidated lung would look very similar to one of the solid organs, the liver or the spleen. So many a time, if you are not careful, we may actually mistake this consolidated hepatized lung, or what is called as the tissue pattern or the translobar consolidation, as the liver. So it's very important to keep your eyes open when we are looking at a consolidated hepatized lung, to ensure that you are able to differentiate this from the underlying solid, the visceral organ. The next important structure is the fractal or the shred sign, which is nothing but areas of patchy consolidation interspersed with normal lung. There are a number of names given to this, called the shred sign, fractal sign, shredded paper appearance. There is a starry sky appearance, etc. So this is the classical bronchopneumonia or a patchy consolidation that we see in many of the, which is probably the more common form of pneumonia that we see these days. This is another important classical sign that we see, what is called as the dynamic hyperinflation. So, sorry, dynamic air bronchogram. So what you see here is a hepatized lung with a moderate effusion around that. But most importantly, if you see within the lung, you find that there are white structures moving in and out, which represents the movement of air in and out of the consolidated lung. Now, these white demarcations are occurring because of the air mucosal interface changes that happen with the movement of air in and out. Now, this is one of the signs that you can use to differentiate a air bronchogram, consolidation from a collapsed lung. Presence of a dynamic air bronchogram will 100% has 100% sensitivity to say that that particular image that you're seeing is because of a consolidation and not because of any other lung pathology. So the three important signs that you would see for a pneumonia would be, one is what is called as the fractal sign, the tissue pattern, and the dynamic air bronchogram. So here again is a video of an image where you see that there is almost a consolidated tissue pattern like lung, very similar to the underlying liver. But one important differentiating point here is that you actually see multiple areas of dynamic air bronchogram within that, if you look at that consolidated lung very, very closely. Of course, there is an adjoining pneumonic effusion as well. That is the video of a fractal sign. As you can see, multiple areas of shredded paper-like sign, or multiple dense areas. There are some interspersed areas of a dynamic air bronchogram as well, but there are some normal aerated areas too. So this is how a fractal or a shredded paper sign would appear. Now, going to the different interstitial shadows that we know about. So what are B lines? As I already explained to you, these are nothing but perpendicular lines which start from the pleural line and run perpendicularly down to the entire length of the ultrasound screen. But that is important. I keep stressing on that word entire length, and at least to a depth of about 6 to 8 centimeters, because it is very easy to get carried away by a comet artifact, because comet artifacts generally end within the first parallel pleural line, and many a time you can actually see the A lines in the presence of a comet artifact, which means you will actually see multiple parallel lines. And if you see multiple parallel lines, the likelihood of that being a consolidated lung or a B line is, or what we call as a B profile, is very, very negligible. Now, this is how a classical B line would look. Initially, the B lines are discrete, as you see, but as and when more and more interstitial edema develops, these B lines get confluence with each other, and they form what is called as lung rockets, and you actually find that these discrete lines become interspersed and flooded with a lot of B lines, and that is when you call that there is a very severe pulmonary edema or a very severe interstitial edema, to the point that many times you may actually start beginning to see areas of shredded sign subpleurally as well. Now, this is what is called as a Z line, which is nothing but a normal artifact, which is a combination of two pleural lines or two A lines, and then you have these comet artifacts. So if you look at this figure or this photograph, you find that the so-called vertical line sort of comes to the pleural next A line and then disappears. Whereas if you look at this image, you find that the B line runs right across with nearly the same intensity across the entire length of the screen, and you find that this particular vertical line fades away. So this is an important differentiating point of what we call as a B line or a lung rocket from a comet artifact, which produces what is called as the Z line. So that's the second A line, and you find that the pleural line, and in between that you find a couple of small vertical lines which seem to fade away by the time it goes midway to the ultrasound screen. So absence of A line is very, very important to make sure that you are actually talking about a B profile, and which indicates a very severe, which indicates interstitial edema. Now, this is an image of when you find that the intensity of the B line is less confluent here, more confluent there. So as you find that the interstitial edema increases, you find that the less confluent line become more and more confluent, and you find a dense mass of B lines on both ends. So this is another image where you find that there is a lot of B line, there is a little bit of subpleural shredding as well that you can actually see. Another image of the B line. This is a very florid pulmonary edema that you can see. Next important pathology is pneumothorax. Now, how do you identify a pneumothorax? There are three important things. One is the absence of a pleural slide. So all this while, be it a B line, when you talk about the A line, when I showed you the first image, I showed you that there is a nice pleural slide that you can see. So absence of a pleural slide should ring alarm bells for an underlying pathology, could be a collapse or the presence of a pneumothorax. So absence of pleural slide plus absence of B lines and the presence of what is called as a stratosphere sign on M mode. If you remember the seashore sign that we spoke about and which is mentioned by the first speaker as well, which that is a normal ultrasound, lung ultrasound. Whereas here you don't find the seashore sign. You do notice that there is a pleural line here, but there is absolutely no differentiating point between the lung slide and the soft tissue shadow. So that slide has gone away. Now this is because of the fact that this is what is called the stratosphere sign, because there is air in between the visceral and the parietal pleura. Now, in addition to these two, if you have a lung point sign, then it gives you 100% positivity to say that this particular patient or the patient image has a pneumothorax. So lung point sign has a true positive rate of about 100, or the sensitivity of 100% to suggest that, a specificity of 100% to say that there is a pneumothorax. Whereas the presence of these three signs can only give you a hint that most likely there is an underlying pneumothorax. But if you find a lung point sign, then even without a chest X-ray, you can actually be rest assured to say that this particular, on that side of the lung or at that particular point, there is a presence of a pneumothorax. So what happens when we talk about a lung slide, or this is how a normal lung would look. This is how a pneumothorax looks. So you find that there is a pleural slide. There is no pleural slide here. And if you put an M mode on the same thing, you actually find that there is this normal looking seashore sign goes away, and you find that there is only a stratosphere sign. So this absence of this seashore sign and the absence of this pleural slide is an important sign to identify that there is the presence of a pneumothorax. Now this is how a lung point would look. You find that this is a collapsed part of the lung where you actually find that there is no pleural slide, and this is the lung which is coming in and moving out of the image. Now what is lung point? It is nothing but the fact that you find that a part of the lung which is above the pneumothorax moves in and out, or does have its normal movement. On the other hand, you find that the collapsed segment of the lung has no pleural slide, because that's where the pneumothorax is actually preventing the pleural slide from happening. So this sign of where one half of the screen is showing a pleural slide, if you put an M mode on this, you will actually find that here you will have a stratosphere sign, and on this part you will probably have what is called as here you will have a seashore sign, and at this point you will have what is called as a stratosphere sign. So the presence of a lung point will give you, will actually make sure that specifically to say that there is a pneumothorax there. Right. Now, some clinical applications of lung ultrasound. You can describe a number of profiles. One is what is called as A profile, where you find that the anterior lung, when you actually start the examination, you find that if you find there are only A lines on the anterior lung field, you call it as A profile. A prime profile is presence of A profile with an abolished lung slide. B profile is an anterior lung slide plus lung rockets. B prime profile is B profile with an abolished lung slide. So whenever there is an abolished lung slide, you actually add a prime to the profile which is already there. C profile is the anterior lung consolidation. A by B profile is an A profile in half of the screen in one part of the lung, and the other half you would actually find that there is a B profile, and the PLAPS profile is sought only after confirmation of the A profile and that there is a free venous network. There is no evidence of pneumothorax. Now it's important to understand these profiles to make sure that you are able to actually have your own algorithm to actually identify different pathologies in the lung in a hypoxemic patient. Now, before I summarize the blue protocol, I'll just touch upon some of the applications of this in the current COVID pandemic era. So if you look at the data from ultrasound, not much literature, but whatever literature we do have, there doesn't seem to be a substantial difference from what we already know with lung ultrasound to other forms of viral pneumonias or ARDS. But one of the important findings that many observers have found, including in our own experience, is that like how COVID-19 affects the lung, as we see on a CT thorax, you find a lot of subpleural patchy involvement. Now, if you find that unlike other viral pneumonias where there is a more diffuse confluent involvement, the COVID-19 lung actually, or the COVID-19 ARDS viral pneumonia lung has a number of areas where there is patchy involvement of the lung. So that is one point which you could use as a possible diagnostic tool, as a possible suggestion to indicate that given ARDS or that given viral pneumonia is secondary to COVID-19. So if you apply a couple of these principles to the already knowledge that we have with lung ultrasound, in a mild disease, it is useful to pick up lung involvement early. So as we know, the first cohort study or the first data which emerged out of Hubei, we know that 86% of patients who presented with asymptomatic disease or very mild disease and near normal saturation had lung findings on the CT. Now, this can be applied to lung ultrasound, and you might find that the presence of early interstitial B lines in an otherwise normal person who is asymptomatic could indicate that you could indicate that this is early involvement and could actually be a marker to say that there is already an involvement of the lung. If you have a suspected SARI patient, this may also give a clue to the patient with possible etiology based on the distribution of the shreds. As I said, subpleural shreds which are scattered and patchy in involvement. And if the patient has comorbidities, the value of assessing B lines as a diagnostic module can become tricky. So it's important to understand that whatever we discuss about lung pathology in the presence of comorbidities like hypertensive disease, cardiovascular disease, or heart failure, or other interstitial lung diseases, chronic interstitial lung diseases, the validity of lung ultrasound becomes a little tricky. Now, to end the discussion, there are a number of protocols. The blue protocol is the one which is the most commonly practiced. So in a hypoxemic patient, this is one of the decision trees which have been used to diagnose the possible pathology for hypoxemia in a given individual. So the precursor or the rider that needs to be understood is that this is not applicable for a normal person. It is to be applied for a person who is hypoxemic. And if the person look at the lung slide in the anterior lung fields, or in the blue points, if you find that there is a B profile, then it could indicate pulmonary edema. If there is A profile and you rule out the possibility of a DVT, then you have to look. It could be a COPD or an asthma or an airways disease. But if you find that with the A profile, there is suggestion that there is a thrombosed vein, it could be a pulmonary embolism, and you have to look at the screen, the heart as well, or look at the PLAPS point for any suggestion of a PLAPS syndrome or suggestion of a consolidation. A by B profile or a C profile is indicative of pneumonia. A B prime profile or an A prime profile with a lung point is B prime profile would mean a pneumonia, while A prime profile with a lung point, we certainly say it's a pneumothorax. While if it is an A prime profile without a lung point, you will have to look for other imaging modalities to confirm the diagnosis. So in summary, the limitations of lung ultrasound is that sometimes you would actually have issues because of poor window, especially if there are dressings, if you have a subcutaneous emphysema or if you have an obese patient. Observer variations are possible, and many times you find that what is noted by one observer may differ or may change with another observer, because we are talking about interpreting shadows, and misinterpretation of signs is possible, like the example that I gave you where mixing up a V line with a comet artifact. So in short, ultrasound is a multifaceted tool today which has played a significant role as a screening tool for within the ICU. Lung is an important organ which is today being screened on a routine basis and has now become a part of our clinical examination inside the ICU. Application of the application of the ultrasound in lung or for hemodynamic monitoring in a good protocolized manner will give a wealth of information, and most importantly, it is easy to use, portable, and cost effective as well. Thank you.
Thank you, Dr. Karanth, for educating us about use of lung ultrasound in COVID-19.